liver test analysis, because I know that's an issue for trying to figure out how to interpret these things. So I just put a bunch of examples in here. And again, I think the best strategy is to look at that and say, is this hepatocellular? Is it cholestatic? Does the liver work? Is this acute or chronic? Can we tell? Because that gets you a long way. And that also will narrow down your differential some, but it also tells you how sick or how bad this problem is. So let's look at this particular set of liver tests. So is this hepatocellular or cholestatic? Okay, so the transaminases are, I don't know, 25 times elevated. Alk Phos is twice. So this is hepatocellular because you've got a much higher elevation of the transaminases than the Alk Phos. Is the liver working? Liver function normal. Okay, so the albumin and the prothrombin time are completely normal. So the liver is quite functional at this time. What about the bilirubin? Why do you think the bilirubin's elevated with this hepatocellular disease? So there's still good liver function to make the prothrombin time, but this is a pretty active hepatitis. There's a lot of liver cells there that are either sick or are dying, and so bilirubin isn't being excreted normally. But in terms of the more critical liver functions, those are still normal. So is this acute or chronic, or can you tell? So why would you say acute? Okay. Right. So because these two are still normal, you can't readily say is this acute or chronic. But this is a pretty healthy death rate for hepatocytes. And if this has been going on for very long, and it's certainly long enough to get your bilirubin up, or there's enough damage there to get the bilirubin up, and you still haven't affected the prothrombin time, this might be fairly acute. So I can't tell for sure, but that would be my guess, because there's a lot of injury going on here. If it had been going on at this rate for the last 2 months, the prothrombin time probably wouldn't be normal. Yeah?
Do we know how many grams
let's see. I would have to go look that up exactly because I haven't looked at that number for a long time. I do know, for example, one of the things we kind of keep in our mind is that you can't get the bilirubin up to much than 4 by acute hemolysis. In part, that's because of the liver's capacity to get rid of bilirubin, but also that's a lot of red cells having been destroyed. So if you completely tie off somebody's common bile duct, it probably takes 4, 5, 6 days to get it up to their 8.5. So this isn't a disease that likely started yesterday, but this could be a disease that started and accelerating maybe in the last 2 weeks, something like that. Okay? So this one, is this hepatocellular or is this cholestatic? Yeah. You have a big high alkaline phosphatase. The transaminases are abnormal, so you know this is coming from the liver, not from bone or something like that. But there's only about a 2 to 3-fold elevation here, and there's about a 6-fold elevation there. So this is a cholestatic disease. You don't have to know what type it is, but at least you've gotten it down to that. Is the liver working? So it's making albumin, it's making prothrombin time. Again, you have the same bilirubin. In this case, your problem may be that a bile duct is tied off or occluded or something, and that's the reason the bilirubin isn't processed. So the patient is jaundiced, but you know that they're still capable of making the clotting factors. So this is not a fulminant liver failure or anything like that. Okay. Is this acute or chronic? Can you tell? No, you really can't tell. You don't know how long this has been going on because your functional tests are both still normal, and bilirubin can go up slowly, it can go up quickly. This could be a cholestatic disease that has very gradually gotten worse over years. It could be one where a stone blocked the common bile duct a week ago. You just really don't know. You just can't tell from this. So you need other information for that. Okay, is this hepatocellular or cholestatic? Okay, so the alk phos is about 2-fold normal. The transaminases are 10-fold normal. This is hepatocellular. This is clearly a less active, injurious per day disease than our first one, where you had 1,500 and 1,700. This liver is destroying a lot more liver cells per day. This one's still destroying liver cells per day, but it's at a lower rate. But it is hepatocellular, okay? Is the liver functioning? Is it functioning normally? Yeah, the albumin and the protein are normal. Now this person is a little jaundiced. Given that there's not a huge amount of injury going on each day, and yet they still got jaundice, this may be something that's been going on for a bit longer and you've actually destroyed more total liver. But you can't say that precisely from these. So I would say you really don't know if it's acute or chronic, but I would say this has probably been going on longer than this one. This one has a huge amount of damage, got the bilirubin to 8. This one's probably been going on for longer, like maybe a number of weeks or a month or two or something like that, or is a chronic disease to get some bilirubin elevated, but you can't really tell precisely. Okay, how about this? Is this a cholestatic or hepatocellular disease? Okay, I heard a neither. Why? Yeah, this is not a liver disease. So you have this big AST. If you have an AST of 2,500 and a liver disease where there's a lot of injury going on, you should have an ALT that's equally elevated. ALT is cold normal. This is not liver disease. Don't start working them up for liver disease. Start looking at them for muscle disease. Something else is releasing that AST. And everything else is normal. The bilirubin is normal, the alk phos is normal, function is normal, but it's not a liver disease. Okay. How about this? Is this cholestatic or hepatocellular? This is 1.7 times the upper limit of normal. This is 10 times the upper limit of normal, or 8 times the upper limit of normal. Okay, so this is a hepatocellular disease, but there's not that much injury going on each day. But you can still use that relative thing to say, we're now in the category, I got to look for a hepatocellular disease. Is this liver working? Is it functioning normally? No, this liver is not functioning normally. So a lot of the liver is no longer there or is no longer working. Is this an acute problem with the liver or a chronic problem with the liver? Okay. So the protein changes quickly. The albumin doesn't. The albumin is telling you what this liver has been doing over the last months. The albumin is fairly low, so this liver has been having problems going on for a long time. Now, is it a year? Is it 5 years? Is it 10 years? I can't tell. Depends on the rate of decline. But this is a chronic liver disease. It has low-grade injury on a day-to-day basis, but it's been going on long enough that a lot of the liver is either dead or not perfused or no longer functional. And so you have an elevated bilirubin with this one also. They all have elevated bilirubins. That's why bilirubin is not actually that useful to tell you much, except to tell you there's a problem. Okay. If you look at the AST and ALT, does that give you any clues as to the reason for the liver disease? Okay, so the ratio is 2 to 1. Now that doesn't say this is an alcohol-related liver disease, but it's certainly very suggestive. So if you look at these liver tests and your resident tells you to interpret them, I would say it's very safe to say this is a chronic liver disease with liver dysfunction, and I'm wondering about alcohol as the basis. The low. Then you have to prove that, but in terms of an initial diagnosis. And you're very safe saying this is a hepatocellular-based disease, the liver isn't functioning, this is a chronic liver disease, and Dr. Mosley today is going to talk to you about cirrhosis, which is the sort of end stage of a lot of liver diseases. And then you speculate as to the etiology. Is this alcohol related? Okay. How about this one? Hepatocellular or cholestatic? This one's easy. You don't have to do much math there. Just remember zeros. You know, look at how many more zeros you've got there. So this is a pretty destructive, on a daily basis, hepatocellular disease. Is the liver functioning normally? And why? How do you know that? Yeah, protime's elevated. Is this an acute disease or a chronic disease? Yeah, this is an acute disease because the albumin is still normal. So this is somebody who probably has something like a rampaging viral hepatitis. And what would your concern be about a person like this who comes in with an abnormal protime? So this patient developing fulminant liver failure. This is somebody who's got an acute disease that is so active, destroying so many hepatocytes a day that the liver can't possibly keep up and regenerate. And this person is going to die of liver failure in the near future. So an active disease, a lot of damage, who already has some liver dysfunction. So what other things might you want to look at to see if there is other evidence of liver failure? We know they're jaundiced. That's a given.
Serum, nitrogen, and glucose.
So glucose. Is this person hypoglycemic? And what's the third element, the trio of signs of liver failure? So you've got abnormal liver function, increased protime. You've got hypoglycemia. Encephalopathy. Is this person got some mental cloudiness? Are they not quite coherent? Can they not quite remember things very well? Again, Dr. Mosley will talk to you about that and show you some examples and things. These are the three things you do not send this patient home with. Okay. How about this one? Is this cholestatic or hepatocellular? What's abnormal? Okay, so you have an isolated elevated alk phos. But that's the only thing that's abnormal. So what's your next question? Is this liver disease? Is this coming from the liver? So it could be. You can have a cholestatic process that at a phase in it is just pure alphos. The other things really aren't disturbed yet, in which case, in this case, the liver is normal. But could the alphos be coming from somewhere else? So where else can an elevated alkaline phosphatase come from? Bone is the other big one. So it can come from the placenta, but even in pregnancy, it doesn't usually get this high. There's an intestinal alkaline phosphatase, but somebody has to come in with something like an acute intestinal obstruction or something, and even then it might not get this high. But you can fractionate that alkaline phosphatase. You can ask the lab to separate it into the liver and the bone and the intestinal components just to confirm that this is liver. So we don't know that this is a liver disease yet. It could well be. So thinking about cholestatic liver diseases is perfectly applicable. But we truly don't know this is liver. You first need to make sure there's not a bone disease going on here. Okay, how about this one? Is this hepatocellular or cholestatic? This one's tough because none of them are that elevated. But the rule still pretty much holds. I would bet on hepatocellular. These are still twice normal. This isn't twice normal. So I would say this is probably a hepatocellular disease that's not very active from day to day in terms of destroying hepatocytes. It's destroying them, but it's not destroying very many per day. So I'd still look in the hepatocellular category. Is this liver normal? Is it functioning? No. This liver is doing a lousy job. Absolutely lousy. Is it acute or chronic? Yeah, this is chronic. The albumin's bad, the prothrombin time's bad. So this is an example of somebody who might be at the end stage of a long history of chronic liver disease, and the underlying damaging process isn't all that active, but most of the liver's been trashed. This is probably an end-stage cirrhosis. And so what you're seeing is that there are not that many active, functioning, perfused hepatocytes left in this liver to do much work. And there isn't much activity going on, but, you know, the damage is all done. Okay. So this could easily be an cirrhotic patient near the end. And given that the liver doesn't work, and given that the daily activity in terms of damage is low, that's another indirect clue to that this is the end of a chronic, long-standing disease. Whereas our fulminant liver failure, which was this one, you're trashing a lot of hepatocytes every day, and it doesn't take that many days until you run out of hepatocytes. So this is a classic acute liver disease that's starting to fail. This is a classic end-stage chronic cirrhotic liver. The other reason I know this is hepatocellular, it should be, best we can do is say it should be, is that we know this is an end-stage process because of the poor function. A cholestatic liver disease that causes liver failure is going to have a really high alkaline phosphatase by the time you have end-stage disease, because it's been going on for a long time, and that becomes the more prominent one. Okay, so from that, now that you have been able to look at your liver enzymes and say, is this hepatocellular? Is it cholestatic? Is the liver functioning? Can you tell about acute or chronic? Let's go to looking at some diseases that are acute hepatocellular, which is the viral hepatitis. So you get somebody whose liver enzymes look like this, and this is a hepatocellular disease with a lot of damage, and they're jaundiced, so they're reasonably sick, but they're still making the prothrombin time. So this is not fulminant liver failure. But this is a pretty severe, ongoing, active liver injury. So a viral hepatitis is a major, and it's acute by history also, is a major possibility here. So you need to find out, is there a virus causing it, and if so, what virus? That means you have to send off serologic tests. So your approach is the broad spectrum one. You send off every test that the lab has. Then they come back and your resident says, okay, you tell me what this means. You're like, okay. I put it off for a while by sending all the test results, all the tests. Now I've got to interpret it. So what do we know about hepatitis A in this patient? So one of the tests is positive. They're not all negative. So what does this person have in terms of hepatitis A? Yeah, this is acute hepatitis A. So bingo, that's your diagnosis. However, you've got some more tests that are positive. You have a positive hepatitis B surface antibody. Okay, so you're telling me they have acute hepatitis A, which is fine. It would fit with the clinical scenario. But how do you explain their positive surface antibody? All the other B tests are negative. Vaccination. Yeah, this person got vaccinated. Now, they could have been exposed to the virus many, many years ago, and the titers for the other antibodies fell below detectable levels, but vaccine is the most likely. Never seen C, D, or E. Okay, how about this set? What do we know about hepatitis A? It's not acute hepatitis A. They're not immune to hepatitis A. So, never seen it, never been there. How about B? We have a surface antibody. We have an IgG core antibody. Yeah, the immune system has seen that virus. This isn't vaccine. The vaccine only has the surface protein in it, so it's the only antibody you can develop. In this case, the person's immune system saw the intact virus at some point in the past, and so you've got two antibodies there. You could have had three. You could have had the E antibody also. But the disease was in the past. The patient's now immune. They won't get it again. What do we know about hepatitis C? Yeah, the virus is there. So they've got hepatitis C. Question is, do they have acute hepatitis C? And that could explain the current clinical picture. Or does this person have chronic hepatitis C, which doesn't give you those high transaminases, and you got to look for another cause? The virus is there, but the antibody, which is an IgG, is negative. And it should be positive in chronic disease. So this is acute hepatitis C. You've explained the patient's disease. Now the only question is, are they going to go on and get rid of it, or are they going to develop chronic hepatitis C? They don't have D, they don't have E. How about this one? What do we know about hepatitis A? They've been exposed to it. Yeah, they've had it. They may never have had a clinical illness. Could have been the vaccine, although the vaccine's not that common yet. But they're immune. So this person does not have acute hepatitis A now, and presumably won't ever get it in the future. B, nothing. C, nothing. D, nothing. So what do we know about E? This is acute hepatitis E. So you have the diagnosis, and it's a rare case. Okay. Just to get life really complicated, we're back to B again. So what do we know about hepatitis A? Past exposure and immune. Okay. And C, D, and E are all negative. So then you are faced with interpreting the morass of hepatitis B serology. And let me tell you, if you do this correctly, you will really impress your resident and your attending, probably, if they know how to interpret it themselves. If you got a liver attending, they expect you to do this. Everybody else will say, oh, that's wonderful. Thank you for telling me what that all meant. Because this takes practice. So what do we know about hepatitis B? Okay, so I'm hearing acute infection. So when I look at these tests, the first thing I do is say, is the virus there? And how do we know the virus is there? So you've got the surface antigen, you've got viral protein out in the blood, and your DNA, which they only run once a week, fortunately, you sent it down, and yesterday was the day they ran the test, the DNA is positive. So you have two tests that show you there is virus in the blood. Therefore, they've got the virus. Okay. Is this replicating rapidly? Is it replicating very slowly or very little?
Rapid.
Yeah, there's a lot of detectable E antigen. So this is a virus that's being churned out of the liver at a fairly fast rate. Still doesn't tell you if it's acute or chronic. What tells you whether this is acute or chronic hepatitis B? Yeah, the IgM core antibody. So if you want the minimalist lab test to say, does someone have acute hepatitis B, what two tests would you send?
Antigen and IgM.
Yeah, surface antigen and an IgM core. Those two should be positive if somebody has acute hepatitis B. Now, we often will send the entire panel, maybe not the E's, because we're trying to figure out sometimes, is this a flare of chronic hepatitis B or is it truly acute hepatitis B? And you kind of want some other information to go beyond that. But if you're looking at a patient in the emergency room with an acute viral hepatitis-like picture and you want to know, do they have acute B, surface antigen and IgM core. Those are the two tests you need. So this is an acute hepatitis B case. Okay, how about this particular case? So hepatitis A, immune past exposure. All right. Hepatitis B, is the virus there? The virus is there. Is there a lot of virus or not very much virus being made? So you have E antibody, and you can't actually detect the DNA very well. It says it's detectable, but they can't quantitate it. So E antibody is usually when very little virus is being made on a day-to-day basis. And in this case, that's so low that the DNA was negative. But the virus is there. Is this acute B or chronic B? Yeah, this is chronic B. Now, could this be somebody who's on the down slope and is way at the end of resolving their B? It's possible, but then their transaminases shouldn't have been 1,500. Okay. C? Not there, never been there. D. Okay, so this is probably somebody who's been chronically infected with hepatitis B. Virus is not being made at a fairly fast clip, but it's still there. They got super infected by hepatitis D. So you have acute D on top of chronic B. And you don't know whether they'll ever get rid of the D or not. It can remain chronic, it can go away. Because the B isn't going to go away. You got that lifelong. Okay, how about this one? What is this person, what viruses has this person run into, and which one? Do they have them both acute? Do you have a combination? So what do you have with hepatitis C? That's chronic C. They've got the virus, but they got it at some time in the past. So that's not causing their big time transaminase elevation, because those have little transaminase elevations. Their acute disease is the hepatitis E. So at some point in the past, they got hepatitis C, they didn't get rid of it, they've got chronic infection. Now they've got an acute disease with hepatitis E. I do have a few patients who have had at least the trifecta, A, B, and C. Okay, so we'll stop there, take a break, and then start with the lecture on cholestatic diseases.